Excellencies, distinguished delegates, ladies and gentlemen, a good morning to you all. I am Zaid Raed Al-Hussein, the President of the International Peace Institute, and I welcome you warmly to this first roundtable discussion of the high-level thematic debate entitled Galvanizing Momentum for Universal Vaccination. Before proceeding further, I would like to remind members of the following mitigation measures that are in place for this meeting. All delegates are required to wear a mask or a face mask covering at all times whilst in public places and in the Trusteeship Council chamber except when directly addressing the meeting. And the size of a delegation for member states, observer states, and the European Union should not exceed 2 persons, and for other observers, 1 person in the Trusteeship Council chamber. We cannot be so indifferent or cool to proceed with this roundtable as if today is only another day business as usual. Not when a member state of the UN is being dismembered so violently. What is happening today, as yesterday and the day before, is monstrous. The Secretary General and the President of the General Assembly have spoken out, and the two must be supported. Russia is a great country. Its people are good, and its history filled with achievement. These actions are the result of one man capable of considerable cruelty, a man of little compassion or charity for others, and a man who now threatens the world. His actions have stained this building badly. How could all of us not feel great shame when confronted with the suffering of the people of Ukraine? You are not obliged to do this, but I will now stand for a minute in silence and solidarity with the people of Ukraine and for all those around the world who suffer from violence. And I ask you to join me, and I am grateful to those who do. Thank you. This first roundtable will highlight and review existing challenges in vaccine production and distribution, optimizing quality, improving absorption capacity and delivery rates in low coverage countries, and ensuring supply predictability. I first invite delegations to view the pre-recorded message of Ms. Melinda Gates.
Hello, everyone. The world is approaching a grim milestone. Nearly 6 million people have died from COVID-19. What's even more sobering is that so many of those deaths could have been prevented, especially in low-income countries. According to modeling from Northeastern University, if countries like Kenya or Mozambique or Bangladesh had been able to access COVID vaccines like the United States or the UK, they could have averted between 70 to 90% of COVID deaths. One of the reasons that this vaccine inequity is so terribly frustrating is that in the 20 years leading up to this pandemic, we watched the exact story play out in an opposite way. Those 2 decades were defined by rising vaccine equality. Countries around the world, international institutions, including the UN, worked together to develop vaccines for some of the deadliest diseases. Then they delivered those vaccines to the hardest to reach places. And the results have been remarkable. Since 2000, childhood deaths have fallen by almost 50%, in large part because of vaccines. It's an important reminder. Vaccine inequality is not inevitable. We know how to get vaccines to everybody who needs them, regardless of where they live. And while the pandemic has changed many things, it has not changed that. I'm confident we can find our way back on the path towards vaccine access for everyone. It might take years, and the job won't be confined to COVID-19 alone. There are other diseases to fight, new pandemics we need to prevent. Still, if we continue supporting the institutions that have proven so effective at delivering vaccines to all, then I believe we can reignite the progress we saw during the first 20 years of this century. We can continue building a healthier world. Thank you.
I thank Ms. Gates for her message. I now invite delegations to view the pre-recorded message of the United Nations Development Programme Goodwill Ambassador, Ms. Padma Lakshmi.
Your Excellency, Abdullah Shahid, President of the General Assembly, heads of state and government, excellencies, distinguished guests. Thank you for inviting me to join this critically important conversation. I'm Padma Lakshmi, and I'm a Goodwill Ambassador for the United Nations Development Programme. The COVID-19 pandemic has exacerbated inequalities both within and between countries. The divide between rich and poor has deepened at an alarming rate. During the first year of this global pandemic, I joined the UNDP in launching a campaign called Half the World. We wanted to shine a spotlight on the fact that those hit hardest by this global crisis are the 4 billion people, half the world's population, who live in poverty and lack any social protections such as unemployment benefits or health care. Those who have the least stand to lose the most and are at risk of falling through the cracks in the recovery process. This includes women and girls. While women have been on the front lines of responding to the pandemic, the crisis has had a disproportionate impact on them and has set back important gains in gender equality. Gender-based violence has soared over these past 2 years, and up to 105 million women and girls could be pushed into poverty by 2030 because of the pandemic. As the world begins to recover, we must ensure that we leave no one behind, especially those who are most vulnerable. This means taking urgent action to make COVID-19 vaccines accessible and available to everyone, everywhere. And we need to do it now. The slower and delayed vaccination rollout in lower income countries have left them vulnerable to COVID-19 while also putting the entire world at risk of further variants, new surges of the virus, and a slower recovery. When it comes to the global strategy to reach 70% vaccination coverage by June 2022, high-income countries have a head start and an unfair advantage. The lack of vaccinations in low-income countries right now means that the countries that can least afford it will have to boost health spending tremendously to vaccinate 70% of their population. If we are to prevail against this pandemic, we need a coordinated and concerted effort that includes reaching the most marginalized and those facing humanitarian crises. The world needs to immediately invest in vaccination equity across production and distribution and ensure no one is forgotten in the rollout. No one is safe until everyone is safe. Access to and allocation of vaccines should be based on principles grounded in the right of every human to enjoy the highest attainable standard of health without distinction of race, religion, gender, political belief, economic, or any other social condition. Accelerating vaccine equity is not only critical to saving lives, but also to driving a faster and fairer recovery from the pandemic for all of us. Thank you.
I thank Ms. Lakshmi for her message. We will now hear presentations from our panelists, and thereafter the floor will be opened for interventions by member states and observers of the General Assembly. I would like to welcome our panelists, Dr. Soumya Swaminathan, Chief Scientist of the World Health Organization. Welcome. Dr. Nicole Lurie, Director of CEPI US and Strategic Advisor to the Chief Executive Officer at the Coalition for Epidemic Preparedness and Innovations. Dr. Tonya Vilofana, Vice President and Global Franchise Head of the Vaccine and Immune Therapies at AstraZeneca. Dr. Peter Hotez, Co-Director of Texas Children's Hospital Center for Vaccine Development and Dean of the National School of Tropical Medicine at Baylor College of Medicine, and Ms. Aurelia Nguyen, Managing Director of the COVAX facility via video link. I now give the floor, and it gives me great pleasure to give the floor to Dr. Soumya Swaminathan.
Thank you very much, moderator, and good morning to everyone gathered here. I'm Soumya Swaminathan. I'm the Chief Scientist of the WHO, and I thought what I would do as we start off on this panel discussion is perhaps to go over some of the statistics. You've heard a lot of numbers already this morning, but just to set the context, I think we know that we have about 430 million cases, and we're getting close to 6 million deaths reported due to COVID. And these are just, I should remind everyone, the reported cases and deaths. We know that in many countries, and particularly again in the low middle-income countries, that access to diagnostics has been as much of a challenge as access to vaccines. And therefore, for every case that's detected, there are probably several hundred cases. It's estimated even up to 1,000 cases in some countries that are undetected. So this is important because the same applies to deaths, and for every death that's reported, there could be 2 to 3 times as many that have actually occurred. And the WHO is still trying to get data on the excess deaths that have been reported from around the world. So there's no doubt that the impact of the pandemic is even higher than what we believe, what we see reported, and also that it's going to have spillover effects on many other aspects of people's lives and of course, the economy. The WHO does surveys on essential health services, and the latest survey that was done early this year showed that of about 130 countries that responded to the survey, 91% still reported disruption in essential health services. This means things like antenatal care, routine immunization for children, non-communicable diseases, tuberculosis and malaria, and HIV treatment. So there are going to be a lot of setbacks to many of our other health programs, including those which are in the Sustainable Development Goals. In terms of the future scenarios and what is possible with the pandemic, I think, as Dr. Tedros said in his speech this morning, that it's really premature that some countries are already celebrating what they consider an end of the pandemic and going back to life as they knew it pre-pandemic. The virus is still out there. It's unpredictable in the way that it's been evolving, and we've seen from Omicron, for example, how quickly it can spread around the world, overwhelming health systems. And thanks to the high levels of population immunity in many countries, the severity of Omicron in terms of deaths was less in most countries than Delta, for example, but it wasn't insignificant. Many countries had more deaths during Omicron than during Delta, just because of the sheer numbers of people infected. So more variants are likely to emerge. We don't know what these variants will look like. They could be intrinsically less severe, but they could also be more. And one thing we know is that they will be able to evade the immunity that we have, so that they can. That's providing an advantage to the virus. So the reason for saying all of this is basically to say that our battle is not over yet, and just getting to the 70% vaccination coverage goals that we've set is the first step really in protecting people. And then we will have to have strategies to plan beyond that. As far as vaccines are concerned, there are 17 vaccines in widespread use today around the world. The most widely used ones are AstraZeneca and Pfizer BioNTech vaccines, followed by J&J and Moderna, and then the inactivated vaccines as well. COVAX has shipped 1.2 billion doses of vaccines just as of this month, and the majority of those have gone to what we call the AMC countries, the advanced market commitment, the countries where these doses are donor funded. They've gone to 144 participants. 40 of these participants, countries, economies, actually started their vaccination program with doses coming from COVAX. And we had challenges last year because of many reasons that we could go into during the discussions, but supply was very erratic and interrupted. And COVAX started off with a goal of delivering 2 billion doses of vaccines by the end of 2021, which would have covered at least 20% of each of the country's populations, which we believed would have protected the most vulnerable, the elderly, the frontline workers, the healthcare workers. So that was the goal, to first achieve high coverage amongst the most vulnerable so that you could reduce mortality, and then go ahead and cover the remaining people amongst the adults. And as the President of the General Assembly said, if we had equitable sharing of the 11 billion doses of vaccines that were actually produced in 2021, we could have probably reduced the death rates at least significantly. So it was only towards the end of 21 that supply started picking up, and in December we had the highest supply of about 340 million doses that went out to countries. We also track what's happening around the world in terms of the uptake and the absorption and the actual vaccination program. And when we look at the different regions of the world, they're very stark differences. So if you look at the world as a whole, today we have still 2.9 billion people who have not received a single dose of the vaccine. But if we look at it by region, then we find that and I'm talking about WHO, the 6 regions, the Western Pacific region has the highest coverage. 81% of the population has completed their course of vaccination. This is 65% in the region of the Americas, 61% in the region of Europe, 53% in the Southeast Asia region, lower 35% in the Eastern Mediterranean region, and then only 9% of people in the African region. Or if you look at the AU countries with a population of 1.3 billion, then it's 12% of people who've had their complete course of vaccination, another 5% who've had at least one dose. So this leaves 83% of people in the AU countries that have still not received a single dose of the vaccine. So that's over 1.1 billion people. That's really the gap, which is very sad to see. We also track interim milestones. So as you know, the WHO called for 10% vaccination coverage by the end of September, 40% of the population to be covered by the end of December, and 70% by the end of June of 22. And when we look at coverage we had at the beginning of the year, still 34 countries who had not yet covered 10% of the population. So these 34 countries are those where even the vulnerable, the most vulnerable, the frontline and health workers, the doctors and nurses, as well as people over the age of 60, had not received even a single dose. And this obviously means that they continue to be vulnerable to the impact of the virus. And if you take the 40% coverage target, which was the end of 21, then we have a larger number. We have 78 countries today that have not reached that. And what it means is that if you're starting with such a low baseline, then it's really hard to achieve the 70% coverage target by the end of June, even if there's a huge acceleration in the pace of vaccination. But that's what really needs to happen, is that we need to step up that pace of vaccination. The supplies of vaccines today are no longer the biggest challenge. We expect anywhere between 16 and 20 billion doses of vaccine to be manufactured in 2022. Of course, we are all aware that the manufacturing is happening in a few parts of the world, especially in upper middle and high-income countries. But this needs to be distributed equitably through the COVAX mechanism, also through the African Vaccine Acquisition Task Force mechanism that have been set up, and we work very closely with them. So to address all of this, we've recently set up the country vaccine delivery partnership. So this is WHO, UNICEF, the Gavi Alliance partners, along with everyone else who's supporting delivery, the World Bank, for example, the Africa Union, Africa CDC, to go to these 34 countries that are at highest risk and develop, first of all, get high-level political leadership and commitment, and then have a one-country plan where all partners really come together, do an analysis of the gaps and what's needed there. Is it health workers? Is it, that they need to be paid? You need a surge in capacity. You need cold chain, more freezers to be brought in. As you know, many of these vaccines need ultra cold chain, which doesn't exist in these countries. Looking at logistics and supply chain of how to get these into remote areas. And then, very importantly, mobilizing communities. Because there's been also, as you all know, a lot of disinformation that was spread about vaccines. And also the fact that some of these countries didn't have access last year when they could see people in other parts of the world were getting vaccinated, and they saw a small trickle of vaccines coming in to their countries, starting, stopping. All of this actually added, we believe, to vaccine hesitancy and a lot of questions about why vaccines were not available for them and whether the vaccines they were getting were in some way second-class vaccines. So there are a lot of these kind of myths circulating that need to be really tackled through very good information campaigns, through having champions, and through other innovative modes of engaging people and dispelling their myths. So there's quite a lot of challenges ahead. As I said, supply is not probably going to be our challenge for 22. It's really helping countries who may have already weak health systems or are in conflict or post-conflict settings. There's also this, we know that there are millions of people that are refugees and migrants. We need a special focus on them. But the good thing is most countries which are hosting refugees and migrants have actually covered them in addition to their own populations. So that's a positive. Perhaps I can stop here, and then I'm sure there'll be more questions that we can address later. Thank you.
Thank you. I'd like to thank Dr. Soumya Swaminathan for her presentation, and I now invite Dr. Nicole Lurie to make her presentation.
Thank you so much, Mr. Chair, and let me thank you first for starting out the session, putting in such important context that we're dealing with a pandemic when we're dealing with yet another incredibly awful situation in the world. I mean, Mother Nature is cruel enough without adding to that the cruelty of individuals. So appreciate very much those remarks. I work at the Coalition for Epidemic Preparedness Innovations, as you heard, and for those of you who aren't familiar with it, CEPI is a relatively new kid on the block as an organization, was formed as a lesson learned after the Ebola outbreak, because the development of Ebola outbreak, of the Ebola vaccine, had started and then paused for close to 15 years before this outbreak, or the 2014-15 outbreak, in which case it got accelerated, and it took another 5 years before it was licensed. And the world at that time said never again, and yet here we are. Never again. But CEPI was formed to develop vaccines for potentially epidemic diseases, and was about 3.5 years old maybe when COVID started, and fortunately, we had started developing and working on development of vaccines for another coronavirus, MERS. And even before the sequence was posted, we're able to call the developers that were working on MERS vaccines and say, we're hearing that this is a new coronavirus. When the sequence is posted, can you pivot? And we'll work out a contract with you in the next 2 weeks, but we think this is a global emergency and we need you to get going. And so one of our early investments was in the AstraZeneca vaccine, and we're delighted to have somebody from AstraZeneca here on the panel today, as well as making, pivotal investments in Moderna and Novavax, which is now authorized for use, et cetera. I want to, and I think I want to just say, while we're all really unbelievably thrilled and excited about the fact that there are now 17 vaccines that are authorized for use, and really excited about the potential of mRNA as well, I think it's important for us to note that these vaccines have been incredibly effective at saving lives, but they're not doing the whole job. They're not taking the threat of coronavirus off the table. And as we already just heard from Dr. Sumi and others, they're great vaccines, but a number of them are not fit for purpose. The cold chain aspects in particular are just incredibly impractical and really impede delivery to many parts of the world. Yeah, we're dealing with it, but at the end of the day, the world is going to need better vaccines if we're going to take coronavirus off the table. As Dr. Swaminathan said too, we know that coronaviruses are bad actors, that we've seen them mutate and cause all kinds of havoc on the world, including with the last Omicron wave. We now know that they've infected a number of animal reservoirs and that they are capable of recombining in pretty scary ways. And so, frankly, we don't know what's next, but we all know we need to be ready for what's next. We spent decades planning for pandemic influenza, and we still need to plan for that. That's another disease that recombines through an animal reservoir. And so we know there's these two virus families, at least, that can threaten the whole world, and that we need to do better. And so I want to sort of make 3 points. One is about the need for continued research and development to make better vaccines, hopefully at the end of the day, single dose vaccines, hopefully at the end of the day, if we can get there, sterilizing vaccines, and either more broadly protective or ultimately some sort of a more universal vaccine that would be fit for purpose to really expand access to the world. And so while we are focusing on the here and now and getting these vaccines, which are very good, out to people, I don't think that we can lose track of the fact that we don't know what's next. And we cannot be unprepared for what's next, either from a scientific R&D point of view or from an access and delivery point of view. One of the things that CEPI has done through its investments that's really worth noting is that with all of the companies that it supported, it secured commitments for access to vaccine for low and middle income countries. This was before COVAX was formed, and we secured the right of first refusal through our contracts, which we ultimately delegated to COVAX. And we need to continue to be thinking as we develop vaccines about how do we work through the development process to secure equitable access to vaccines for the future as well. We know even now with the variant vaccines that many high-income countries have already secured a right of first refusal and advanced purchase commitments for adapted vaccines if they're needed, again, potentially leaving low and middle-income countries in the dust if COVAX doesn't have the money to make those financial commitments. So we're not out of this yet, either from an R&D perspective and, as we know, from an access perspective. The second thing that I think we all have recognized is about the importance of distributed manufacturing. We've seen incredible vaccine nationalism around the world. We know that in particularly on the African continent, but other places as well, there has not been a lot of manufacturing capacity. And now there's a lot of work both with bilateral relationships between companies and countries and through WHO to expand manufacturing capacity around the world, and particularly in Africa. If we're talking ultimately about expanding vaccination, this is relevant not just for COVID, but for all kinds of other vaccines that may be coming down the pike. Hopefully effective TB vaccines, hopefully someday an effective HIV vaccine. We're starting to see the leading edge of malaria vaccines, et cetera. And so if we're really talking about access to vaccine, we also want there to be vaccine manufacturing that's much more close to the source of where those vaccines are needed. And that also, I think, is going to help a lot with vaccine confidence at the end of the day. So I like to say, at the end of the day, we need not only the factories, but we need the technologies that are better, faster, cheaper, easier to use, and closer to the source. And so over the next 5 years, CEPI is intending to help fund and support those innovations that will go into the factories, that will make it better, faster, cheaper, easier to use, and closer to the source. But of course, if you're going to have more manufacturing capacity, they need stuff, as I mentioned, to manufacture in an interpandemic period. They need a business case, and that means they need a demand for vaccine. So where is that going to come from? Well, we heard already that we've got an incredibly robust global system for pediatric vaccines, and that's great. But there's going to be a bunch of market competition potentially there. One of the things that I think is a real untapped opportunity, and we ought to take advantage of building from COVID, is that most of the world doesn't have a really good platform for adult vaccination. We haven't had a great way to think about vaccinating healthcare workers in a crisis or vulnerable adults in a crisis. And we're learning how to do that, frankly, around the world through COVID. One of the things I think we need to be sure about is that as we think to the future, we don't let that nascent system of adult vaccination and that platform for adult vaccination die, but instead that we strengthen it, both in the name of pandemic preparedness and in the name of continuing to extinguish diseases that continue to kill lots of people and threaten people, whether it's on a regional basis or a global basis. So at the end of the day, I think we end up with a little bit of a three-legged stool where we've got R&D and new vaccines coming down the pike. We've got this manufacturing piece, which I'm very excited about its potential, but it can only succeed if it's got that business case and the demand. And so we've got potentially strengthening adult vaccination platforms for that to happen. And then we're talking about, at the end of the day, not only expanding vaccination for the here and now, but having a system that's going to be able to do that much more effectively for the future. So I think I'll stop there. Thanks.
I thank Dr. Nicole Lurie, and I turn the floor now to Dr. Tanya Villafana. You have the floor.
Thank you, and it's a pleasure to be here with everyone this morning. Yes, it's a pleasure to be here this morning and to be with so many of our partners that we've worked with so closely over the course of the past 2 years as we've dealt collectively with this pandemic. 2 years ago, the outbreak of the pandemic galvanized public-private partnerships on a global scale. As a scientific community, we combined our expertise and pooled our resources at a critical moment to reach a common goal. In less than a year, vaccines were researched, developed, tested in clinical trials, approved by regulators, and have begun to be supplied thanks to unprecedented scientific collaboration, such as the partnership that we've had with Oxford University. No vaccine in history has been developed or delivered so quickly. Today, as many of the panelists have said, over 17 vaccines have been approved around the world, and over 10 billion doses of vaccines have been delivered, demonstrating the success of partnership that formed over a short time frame to deliver against the odds. That said, as our panelists have been discussing, equitable access to vaccines around the world remains a pressing challenge. The emergence of the Omicron variant is a stark reminder that as long as parts of the global population remain unvaccinated, we are all at risk. The scientific community can be proud that existing vaccines continue to offer robust protection against new variants of concern, But our R&D efforts are far from over. We must continue to collaborate and innovate to solve new challenges as they arise. At AstraZeneca, we've taken major steps to ensure equitable access to our WHO, EUL, and EMA-approved COVID-19 vaccine. Together with our partners, we've supplied more than 2.6 billion doses of our vaccine to over 180 countries, a quarter of all vaccines globally. 2/3 have been delivered to low and lower middle-income countries. The vaccine can be administered within existing healthcare settings. It is easily stored, transported, and handled at normal refrigerated conditions. In less than a year, we shared our technology and built a global supply network with more than 20 partners across 15 countries. You can see that, for example, by our voluntary licensing agreements with the Serum Institute of India and Fiocruz in Brazil, which have facilitated the scaling up of manufacturing across the world. We believe the most effective way to address vaccine inequity is for manufacturers with specialized expertise to support the timely transfer of technology and know-how to manufacturing partners globally, where production can be grown at scale combined with affordable pricing. Collaboration with multilateral organizations is also critical. At AZ, we were proud to be the first manufacturer to join the COVAX facility, which has provided over 300 million doses with our partners to date. We estimate that our vaccine has helped to prevent 50 million cases, 5 million hospitalizations, and save more than 1 million lives. So we believe there is cause for optimism, and we believe that vaccine supply bottlenecks are set to ease this year as global capacity continues to increase significantly. We feel strongly that we need to shift our efforts to supporting country absorption and last-mile delivery. Many countries need greater support to establish cold chain capacity, as was mentioned, build more robust data systems, tackle vaccine hesitancy, and address gaps in local workforces. This historic public-private collaboration has already delivered the most beneficial way of protecting against COVID-19. It must continue going from strength to strength to make vaccine equity a reality. Thanks, and I'm happy to answer questions during the discussion.
I thank Dr. Tonia Villafana for her presentation, and I now turn the floor over to Dr. Peter Hurtis.
Thank you so much. It's a true honor for me to be here, and I very much appreciated your opening remarks, Mr. Chair. My grandparents are from Western Ukraine, and so this day has special meaning for me and for my family. They're from Tarnopol in Western Ukraine. I'm a bit different from the other speakers in that I'm actually an academic and a working scientist that develops vaccines for poverty-related diseases, including a low-cost COVID-19 vaccine that has now been released for emergency use in India for both adults and children, and soon, hopefully, Indonesia and Botswana and elsewhere. Before I continue, I also want to acknowledge my longstanding friend and colleague, Stuart Simonson, one of the Assistant Director Generals at WHO, and it's great to see him here today as well. The start of this is kind of interesting. I was trained, my MD and PhD, 15 blocks north of here at Rockefeller University in Cornell, and so it's very meaningful for me to be invited back here. And at that time, Rockefeller had for its motto pro bono, Scientia pro bono humani generis, which is science for the good of humankind. And I took that very literally and devoted my life to developing vaccines that the pharma companies won't make because they're vaccines for the world's poorest people. For instance, we developed a vaccine for female genital schistosomiasis, probably the most common gynecologic condition of girls and women living in poverty on the African continent. That's now in phase 2 trials, a hookworm vaccine, a Chagas vaccine for Latin America. And then about 11 years ago, we realized there was going to be a need for coronavirus vaccines, and they were orphaned just like our parasitic disease vaccines. Nobody cared about coronavirus vaccines. So we started developing vaccines for SARS and MERS. And our approach has always been that they have to be low-cost, simple, accessible vaccines if they're actually going to be used. And the major technology that we focused on is microbial fermentation in yeast to make a genetically engineered recombinant protein. And the reason that's the case is because that capability has been in place for decades in Vietnam and Bangladesh and Brazil and Cuba and Indonesia and at least half a dozen, maybe more, low and middle income countries, so that if you want to empower the world's low and middle income country vaccine manufacturers to not be so dependent on the pharma companies and actually make their own vaccine, that's the technology to use. And so we pivoted that around, and I say we, our Texas Children's Center for Vaccine Development is co-headed now by myself and my science partner for the last 20 years, Mary Elena Batazzi. And when we got the COVID-19 sequence, which appeared online on bioRxiv in January 2020, we said we got this because we've made vaccines for SARS and MERS. We could do this for COVID-19. And the vaccine that we've produced is now the lowest cost of probably of all the COVID-19 vaccines, 145 rupees a dose, which is about $1.90 a dose. No limit to the amount you can make. It's a vegan vaccine, no human cells, no animal cells, no human protein, no animal protein, so it addresses a lot of the vaccine hesitancy issue. And we decided we were going to do this with no patent, no strings attached. And we did that because we were seeing all of the hand-wringing about what was going on with the pharma companies, and I said, look, you know, when your house is on fire and you can make one phone call, you don't call the patent attorney, you call the fire department. So we wanted to be the fire department. And so there's no limit to the amount you can make. And so that's underway. Now, we've licensed it now to, with, as I say, no patent, no strings attached. We help in the co-development. We're on regular Zoom calls. We actually help in the assay development. We do at our own expense. We do whatever we can to help in that. And now it's been released for emergency use in India by Biological E, one of the big vaccine producers there. They've produced 300 million doses already and are going out to produce 140 million doses per month. Bangladesh, similar. Indonesia, because it's a vegan vaccine, they can also make it as a halal vaccine for OIC countries. And now, in collaboration with Patrick Soon-Shiong and the president of Botswana, building a big production facility for making the vaccine in Botswana as well. And so, you know, one of the big struggles that we had, we did have some CEPI support, but largely with no Operation Warp Speed support from the U.S. government and very little G7 support, because the focus was so heavily biased towards the multinational pharma companies. And everybody was so focused on innovation, speed and innovation, speed and innovation. And you got some very interesting vaccines for mRNA and adenovirus and particle vaccines. I myself was the beneficiary of the Pfizer-BioNTech vaccine, and I'm grateful for it. You know, could have saved my life for all I know. Maybe it did. But the problem when you focus only on speed and innovation, as any engineer will tell you, there's a learning curve before you know how to make 10 billion of anything for a brand new technology. And so the failure was not COVAX. COVAX was a very well thought out mechanism. I think it's brilliant in its design in many ways. The problem was an upstream policy failure. Speed and innovation at the expense of everything else, without recognizing the importance of making vaccines locally in low and middle income countries. And so the problem is the ecosystem needs to be more balanced. I recognize the importance of the multinational pharma companies, and let's give them credit. Let's face it, a lot of the vaccines that the Gavi Alliance uses every day to save lives are made by the multinational pharma companies. So they're a critical player. The problem is everything is so tilted to the exclusion of everything else. And we need to find a way to balance it more to support those vaccine producers in low and middle income countries who can do this and are doing it right now. I also think we have to balance out the national regulatory authorities, because right now the WHO and this has been going on for decades, pre-Soumya, pre-Dr. Swaminathan, is that the stringent regulatory authorities are exclusively in North America, Europe, Australia, and Japan. They're the gatekeepers who can decide, what's good for the rest of the world. And we have to call it what it is. It's old-fashioned colonialism. And we have to balance that with giving stringent regulatory status to at least one or two low and middle income country vaccine national regulatory authorities who we've worked with, for instance, DCGI in India or Anvisa in Brazil. They should have that right to help people in low and middle income countries. I think there are other roles for these vaccines. I think, for instance, we underuse these vaccines for purposes of diplomatic purposes. For instance, there are those who would like to see us work jointly with North Korea to make the vaccine. So why can't we work with the International Vaccine Institute in South Korea to help North Korea make this vaccine? Why can't we help Iran? So I served as U.S. Science Envoy in the Obama administration for vaccine diplomacy in the Middle East, but I think it's underused. And lastly, I'll say I think we also need to finally recognize how devastating the anti-vaccine movement is. And unfortunately, the other hat I wear is I have 4 adult kids, including Rachel, who has autism and intellectual disabilities. And a few years ago, I wrote the book, Vaccines Did Not Cause Rachel's Autism, to fight against the fake anti-vaccine movement. And so I've been public enemy number 1 or 2 for a number of years. In fact, they call me the OG villain, the original gangster villain. So, Mr. Chair, you've invited the original gangster villain to come speak in the United Nations today. And they've grown in strength and size, and predictably so, and we've been warning about them for a long time. But now it's taken on a new level. And so and I don't even call it misinformation or disinformation anymore. I call it what it is, anti-science aggression, and it's a killer. And over the last 8 months in the United States alone, 200,000 unvaccinated Americans have thrown their lives away needlessly out of vaccine defiance, out of vaccine refusal. So anti-vaccine, and it's happening now in Canada. We're exporting this to Western Europe, and now you're seeing this in Africa as well. And it's a killer movement. And I would argue it's killed more people. Anti-science aggression has killed more people than all of the things we talk about here in the United Nations, killing more people than nuclear proliferation, killing more people than global terrorism, killing more people than cyber attacks. Yet we don't recognize it as such, and we don't recognize how evil this force has become. And so I think it's very important to look at it through that lens to really take it on. So again, thank you very much for this opportunity. This is very meaningful for me personally, and I appreciate it. Thank you.
I thank Dr. Peter Hoetes for his presentation, and I now turn the floor over to Mrs. Aurelia Nguyen, Managing Director of the COVAX facility. Please, you have the floor.
Thank you, Mr. Chair. And I join my fellow panelists in thanking you for your opening remarks. Excellencies, distinguished delegates, ladies and gentlemen, thank you for having me today. My name is Aurelia Nguyen. I'm the Managing Director of the COVAX facility at Gavi. And thank you to His Excellency, Mr. Shaheed, for his incredible support in keeping equitable access to COVID-19 vaccines as one of the top priorities for the 76th UN General Assembly. At this critical juncture of the pandemic, maintaining political support and momentum for vaccine access is really critical. We've been in COVID-19 pandemic for more than 2 years. Understandably, many countries, leaders, people have grown quite weary. And the perception that Omicron has somehow made the virus less dangerous has also created a bit of a false sense of security that the pandemic is over. But I think we have to make no mistake. We are still in a state of global crisis. We have around 3 billion people still not having received a single dose of vaccine, and the need for universal vaccination is absolutely paramount. And it's enabling equitable access to COVAX that really remains our best hope for protecting people and ultimately bringing this pandemic to an end. We faced huge challenges in COVAX, but COVAX is delivering. And so far, we have 1.2 billion doses that have gone to 144 countries. And 90% of these, so more than 1 billion doses, have gone to low and lower income economies through the Gavi COVAX Advanced Market Commitment. This rollout is, I mean, it's nothing short of remarkable, the largest, most complex global deployment of vaccines ever. And also, I think beyond that, I think a demonstration of what can be achieved with global solidarity and with multilateralism. And we're going to be closing the vaccine equity gap with two factors, really. Helping countries to roll out vaccines as quickly as possible, and ensuring that COVAX has the resources on hand now so that we can support any needs for the future. We've in a little bit of a different paradigm now, where we have COVAX having supply that is able to meet demand. It's really crucial that we're able to provide countries with the catalytic delivery funding that's necessary so that we can make these shipments of vaccines into shots in arms. And so this is really where funding is still urgently needed so that we can provide the technical assistance, we can provide operational funding and do capacity building to really make sure that absorption rates go up in countries and communities where it is still very, very low. In terms of future procurement, it's clear that countries have concerns related to several unknowns, and that may impact future strategies. So variant adapted new vaccines or pediatric vaccinations. We've really learned, I think, the hard way, the consequences of delayed funding. And what delayed funding means is that we end up in the back of the queue. And that experience, I think, has underscored the importance of having early funding and of having risk mitigation strategies which give flexibility and the ability to diversify so that we can respond to unexpected challenges, because unexpected challenges there will still be. And so it's really sort of within this sort of context that we're continuing to leverage. We have existing advanced purchase agreements with manufacturers. We've been benefiting from dose donations. And now Gavi is really seeking to establish a pandemic vaccine pool where we can have 600 million vaccine doses, which is really to have a mix of solutions so that we can proactively address the next challenges of this pandemic and really have an important foundation for future pandemic preparedness. And then furthermore, to ensure that donated doses reach people, we want to make sure that we can provide additional support for ancillary costs. So that's the syringes and other equipment, transportation and insurance to make sure that the doses ultimately get to the people who need them. So to achieve all of this, we're looking for an additional $5.2 billion of funding for COVAX by the end of March. And that's really going to be the essential part to get ahead of the pandemic and bring us closer to universal vaccination. To beat COVID, to protect ourselves from the ongoing threat of new and potentially more dangerous variants, we have to keep evolving, we have to keep learning, we have to keep finding new ways to work together and building and leveraging on what already works. This is going to be really important in terms of laying the grounds for a strengthened health architecture, and that's going to be essential for future pandemic preparedness. So I'm counting on everyone's support in the next phase of COVAX in 2022, and I want to really thank you for the continued support to Gavi and COVAX and for your really deep commitment as we continue to work together on our shared goal of vaccine equity. Thank you.
I thank Mrs. Aurelia Nguyen for her presentation, and I now open the floor for comments and questions. And since there is no established list of speakers, participants are encouraged to engage interactively and also avoid reading from written statements. Delegations wishing to speak, of course, are requested to press the microphone button on the console in front of them. In this regard, delegations are encouraged to limit their interventions to 3 minutes so that all requests from the floor can be accommodated. and delegates may also submit their full-length statements to the Secretariat to e-statements@un.org. The text of the statement submitted will be posted on e-statements in the UN Journal. I thank you for your cooperation. And perhaps I can abuse my position as moderator to throw out two questions after we take questions and comments from delegations. We'll, of course, return to the distinguished panelists for their responses. But perhaps to get the ball rolling, I just have two questions, if I may, and if the panelists could think about them, and then I'll get back to you at the end. We speak of course, vaccine equity, the gap, the deficit that exists, the global picture when it comes to the pattern in which distribution has taken place, and Peter referred to vaccine colonialism. The impression from the Global South is that it's very much that. But what about within countries? We speak of low and low-income countries and the poor. But the poor are often poor because of structural discriminations. And the protections of the state in many countries do not exist as a matter of fact or even as a matter of law when it comes to them. Of course, the international bodies, whether they be intergovernmental or non-governmental, wouldn't want to be a party to the furtherance of such discrimination. So what guarantee is there that you're not abetting something that already is an issue within states? And two, if I may also delve a little bit deeper into the conflict zones, and Dr. Sumya, you spoke about this right at the beginning, but the non-governed spaces, the conflict zones, the Gavi board made available, or has made available, a reserve of 5% of Gavi COVAX AMC funding. Is this enough, given the scale of what we see around the world? The Security Council, of course, passed a resolution in terms of urging member states to do more to support people caught up in conflict zones. And where are we on that? With that, I'd like to... who do we have? Okay. So I'd like to turn over the floor to the distinguished representative of Latvia. You have the floor.
Thank you, Mr. Moderator, for giving me the floor. At the outset, let me express Latvia's full solidarity with Ukraine in our unwavering support for Ukraine's independence, sovereignty, and territorial integrity. Latvia condemns in the strongest possible terms the Russian Federation's unprovoked and large-scale aggression against Ukraine, which is a gross violation of international law and the UN Charter. We call on the international community to condemn Russia's actions and provide Ukraine with the necessary humanitarian assistance. We demand that Russia immediately ceases its military actions, unconditionally withdraws all its forces and military equipment from the entire territory of Ukraine. Distinguished panelists, during the pandemic, the spread of misinformation has also significantly challenged vaccination efforts. Vaccine hesitancy can also add to the aggravation of absorption capacity. Therefore, my question to you is, what, in your experience, are the most effective strategies for addressing vaccine misinformation and improving vaccine confidence in communities? Thank you.
Thank you. And I now turn over the floor to the distinguished representative of China.
Thank you, Moderator. China would like to thank President of the General Assembly for holding this high-level debate on COVID vaccine. And I would also like to thank the panelists for their briefings. To merge the gap of vaccine, we need to increase vaccine assistance and the co-production of vaccines. Particularly, we need to help the developing countries to establish vaccine production capacity. Just now, the panelists have also emphasized this point. From a vaccine assistance point of view, China last year has provided 2 billion vaccines, COVID vaccines, to 120 countries and international organizations. This year, we'll continue to provide 1 billion COVID vaccine to African countries. February the 11th, China signed an agreement with COVAX, and we will donate $100 million to COVAX for use in vaccine in the developing countries. From the perspective of co-production, China is the earliest to support the wave of vaccine international intellectual right, and we have engaged in co-production with the developing countries at the earliest stage. Up to now, China's vaccine enterprises have cooperated with 20 countries in production of vaccine, including Egypt, Algeria, Morocco, and other African countries. Vaccines from China not only produces in China, they can also be produced in Africa and can also be co-produced by China and African countries. This will further strengthen the capacity of local production in African countries. The strengthening of such production capacity means not only the COVID vaccines can be produced in those countries, but also vaccines for future pandemic. What I want to ask the panelists is, how can countries to further advance the waiving of intellectual property rights and transfer knowledge and technology to the developing countries so that those countries can produce locally those vaccines? Thank you.
I thank the distinguished representative of China. So we have a handful of questions. Perhaps we can go back to the panel again, and we go in the same order, or if there's anyone who wants to jump in and answer all the questions in one go, we can do that. Let's start with you, Dr. Samia, please.
Thank you very much for those really interesting remarks and questions. So, moderator, perhaps starting with the very important issues that you raised on the inequities in access within countries, not just between countries. And I think this is very important because when we monitor routine immunization, childhood immunization in countries, there is always a gradient of coverage from high income, the highest coverage being in the highest quintile of the country's population, and the lowest coverage always being in the poorest sections because they live in remote settings, or they do not have as much access, it's not as convenient, and also the information perhaps doesn't reach them. So the same trend is likely to be observed with the COVID vaccines, though there isn't as robust data, and in fact it points to the need also to have robust data systems in countries. I mentioned earlier that we don't even know how many people are infected in many countries or how many have died. And similarly for adult vaccination programs, which are generally not routine in many countries, we're still getting the data from them. But the other thing about COVID vaccines, of course, is that we want to target the most vulnerable first, that is the more elderly. So in terms of inequities in coverage, again, we find some countries where people above 60 have relatively low coverage, even though younger people may be coming forward to get vaccinated. And that means that those people are still vulnerable. And when there's another wave, they may be affected. So I think it's very important for countries to look at their own data to see who have they covered and who have they missed. And why are those people being missed? The elderly are also less likely to be able to get out of their homes and travel to centers. So many cities actually set up programs to go house to house to find those. Disabled is another group of people who cannot go. And so I think it's really important to see who's the population in my country. I want to make sure that I've covered, and where are the gaps, and what strategies can I have to address those gaps. It's the same with the conflict settings and the humanitarian zones. I think what COVAX, our approach was to appeal to countries to cover everyone that's living within their borders. Doesn't matter about, nationality, because it's just doesn't make epidemiological sense to leave some groups unprotected, because the infection will continue to spread. And I must say that most countries have taken that approach, have not excluded non-nationals. The COVAX does have this 5% buffer for humanitarian use, and that is being requested by agencies like MSF, for example. But the ideal is for countries to use their own supplies. On the question, the comment from Latvia on misinformation and vaccine hesitancy and what are the most effective strategies to improve vaccine confidence, I think this is actually a very profound question and goes back to what Dr. Hotez was saying earlier about a whole movement which appears to have gotten a lot of legs now, especially due to social media, of misinformation, anti-science, and it's been true for certain drugs that have been promoted as well without any evidence. Drugs like ivermectin and hydroxychloroquine, which were proven not to be effective for COVID, were still being promoted by a number of people who were telling others to take those drugs rather than get vaccinated. So I think we need a very strong behavioral and social science approach to this. It has to be multidisciplinary. It's not just for the doctors or scientists. We cannot address this on our own. And so the WHO actually set up a whole area of program of work called infodemiology, or really handling what's called infodemics. So in fact, Dr. Tedros in February 2020 talked about an infodemic as being a problem along with the pandemic. And so we have now a very large global convening of interdisciplinary experts, and there's also a research agenda that's been developed. So I think this is an area that we need to address because it will impact other routine immunization programs. And the last point I'd like to make is on the point of that China made, and again, very important for distributed manufacturing to really strengthen capacity. At the World Health Assembly last year, member states actually approved a resolution on local production, encouraging WHO to do everything possible to strengthen and enhance local production, not just for vaccines, but for all health products, for drugs, for biologics, for as well as PPE and etc. So we have two mechanisms now that can be used for any group that wants to transfer their intellectual property, know-how, technology. The first is called the COVID Technology Access Pool. This was announced in May of 2020 by the President of Costa Rica and DG Dr. Tedros. It's a pooling mechanism for knowledge, for intellectual property, for technology, for diagnostics, for vaccines, for drugs, and also for other products like ventilators. So we have a lot of interest from countries, and to date we have only one technology. It's a diagnostic antibody test that an agency from Spain actually donated that into the CTAP, but we hope that this can actually go a long way. And the second is the mRNA Technology Transfer Hub that we set up in South Africa, and we've now announced global spokes. There were over 20 countries that were interested in absorbing this new technology and in building it up within their own countries. So we have now spokes that have been announced from all over the world, and more probably to come, which will form, again, a global network, I think, of capacity to work on RNA vaccines. And as Dr. Lurie was saying, it's not just for COVID. We need this capacity to be able to quickly pivot to making vaccines for whatever may be the next pathogen. It could be influenza, it could be a whole number of other viruses that could cause the next pandemic. And so having that distributed capacity is going to really hold. So we are at the beginning of that process, but I hope in the next year or two we will see a lot of progress. But also I think we have to remember what was said about having an investment case, making sure that the market shaping takes place, that procurement and pricing for these vaccines is looked at. And the good thing about the mRNA technology, and I'll end with that, is that there's a lot of innovation happening in making it more user-friendly. So mRNA without the ultra-cold chain would be and also reducing the cost of production. So there are many biotech companies who are actually also interested in sharing their technology, unlike the large companies which have not shared their know-how. We have a number of others who are interested in working with the mRNA hub. So hopefully we'll see a lot of activity happening on that front. Thank you.
Thank you, Dr. Soumya. Dr. Nicole Dury, I saw you nodding in agreement furiously, so please.
Right. So I think Dr. Soumya's comments have been really comprehensive. I can take off my mask so you can hear me. Have been really comprehensive in response to these questions. And yes, I am in violent agreement with her about all of those points. I might just want to amplify a couple of issues. And I think that this issue about equity within countries is just so important. You know, and somehow we sometimes think this issue about inequality is limited to a couple of countries and a couple of high-income countries in particular. And I know, you know, being here, it's been a profound issue here in the United States. But there is structural inequality and structural racism all over the world. And I think it's something that we need to recognize and need to acknowledge and need to think about how all of the systems of power, you know, sort of play out in economic opportunity and educational opportunity and the kinds of situations that put certain populations at higher risk for getting ill. And frankly, then for the issues of vaccine equity. You know, prior to coming to CEPI, I served in the U.S. government where my responsibilities were to manage the response to all kinds of public health emergencies. And in every single emergency, it's people who are poor, people who are low income, that fare the worst and have the worst outcomes. So there is no and that's all over the world. So there is no reason at all to think that it should be different there. I think the comments too pointed out something really important, which I also really agree with, which that every country has to say, who's the population of my country and what do I need to do? But you know what? A lot of countries, including a number of high-income countries, don't really have a great idea of who the population is in their country. And especially when I think you mentioned, especially people with certain kinds of disabilities, those people don't go out, they're not seen, right? And often health authorities just don't even know that they exist unless something terrible happens. And so that also gets, I think, to the issue of strengthening the core public health capacities of every country. At the end of the day, yes, it is the role of public health to know who your population is, so you can serve them. But that is something that I think is incomplete in many, many countries. And I think it's just worth noting. I might just say one or two other words about conflict zones, too, because I think that that's really important. And actually, it's been really gratifying, I think, for all of us to see countries being willing to vaccinate within their borders. And it's fabulous that doses were set aside for conflict zones. And in fact, at least one company, maybe more, has also sort of set aside all these very special requirements about countries waiving liability and indemnification requirements for companies to be willing to ship doses to conflict zones, and that's been welcome. But even with that, there are unbelievable legal and logistical hurdles of who can legally ship to a conflict zone, who can receive them in a conflict zone, on and on and on. And unfortunately, those kinds of things, which are often really overlooked, I think are slowing the delivery of doses sometimes to conflict zones and making it really, really hard. And it's just a good example of how I think you have to pay attention to all of these points of failure along the chain, and just be sure that you cover them all. I don't have much more to say about vaccine hesitancy other than It's a huge global problem. I think, though, it's probably worth noting that in addition to the infodemic pieces that spread by social media, there are a couple of countries that are really notorious about spreading this misinformation. And they do it to help destabilize countries, to drive wedges between populations, as we are seeing right now in Ukraine. And it's something else that I think really contributes to a lot of instability in the world, and we need to find ways to stop it.
Thank you, Nicole. Peter, I assume you're in agreement. Again, it sort of fits in with what you were saying.
Yes, Mr. Chair. These are brilliant comments, and I support them fully. A few words about the misinformation, because I think there is not really a good understanding of what the anti-vaccine, anti-science ecosystem is actually comprised of. You know, we focus a lot on the social media companies. In fact, our U.S. Surgeon General made an effort to focus especially on Facebook, and indeed they are responsible for quite a bit of dissemination of the misinformation. But what most groups are unwilling to go after are those generating the content. And to remember that these are not grassroots organizations. These are non-governmental organizations and some governmental organizations that are deliberately doing this to weaponize health communication. So I identify about 3 or 4 big buckets, and I think it might be instructive to look at those. Number one, not in any particular order, but one is what the Center for Countering Digital Hate, and it's amazing we have to have an organization called the Center for Countering Digital Hate, headed by Imran Ahmed, based in D.C., calls the Disinformation Dozen. These are non-governmental groups spreading around 2/3 of the disinformation. Those are extremely important. No one has really shown much of an appetite to go up against them in terms of legal frameworks and other policy mechanisms. We have to dismantle them. The second, as Dr. Lurie points out, there are state actors that are doing this as wedge issues to drive apart democracies, and the most egregious is Russia, as documented by U.S. and British intelligence. They are using a system of bots and trolls to use this as a wedge issue to pit one side against the other using anti-vaccine disinformation. And by the way, probably nobody has suffered more from Russian disinformation than Russia, because Russia has one of the worst vaccine hesitancy problems of any country. The third, and the hardest to talk about, is the authoritarian regimes, including the authoritarian regime from the far right in the United States. So this has generated an enormous amount of disinformation. And in the U.S., it's coming from the conservative news outlets, so Fox News, night after night after night, floods the U.S. airways with anti-vaccine disinformation. And they not only go after the science, but they go after the scientists. So 2 weeks ago, I had to endure 2 nights, successive nights of attacks on from the Fox News anchors. And it's very aggressive and very destructive. And as I said, 200,000 unvaccinated Americans have lost their lives, very much along a partisan divide. In fact, the New York Times calls it red COVID. Because red being Republican, blue being Democrat. And I think this is, and it's also coming from a cadre of contrarian intellectuals or pseudo-intellectuals, and it's coming from about 6 members of the U.S. House of Representatives and the Senate that are using this as well. And I think that's the hardest for us to talk about, who are involved in either academic pursuits or as political scientists or those involved in diplomacy, because it's impolite. We're not supposed to talk about Republicans and Democrats or liberals and conservatives. We're supposed to be above that. But I've not found a way to talk about it other than to talk about it. And it's not that I'm politicizing the vaccines. They're politicizing the vaccines. And what I'm saying is it doesn't belong. Uncouple the anti-vaccine, anti-science from the political right, because it's killing so many people. And it's a very... And I think the Biden administration and the U.S. has struggled with it now, but we're exporting it. You've seen now how we've exported this to Canada, for instance, with the truckers. That's all coming from the far right elements. And if you see the anti-vaccine rallies in Washington, they're now the Proud Boys are marching with us. So this has become a front and center aspect of political extremism, and this has been a very, very tough element to sort out. And we're seeing it in Brazil. We're seeing it, wherever you have authoritarian regimes, we are seeing a very strong anti-vaccine movement in many parts.
Thank you, Peter, for those comments. We turn now to Tanya. Would you like to make some comments?
Yes, thank you so much. And I'd like to talk a little bit about the misinformation piece. And I guess I have the privilege of, prior to joining industry, I worked quite a bit in the field in sub-Saharan Africa and in other parts of the world doing vaccine trials, so doing HIV vaccine trials, doing malaria vaccine trials, and in the context of working in the field and in communities, had a lot of lessons learned about how to speak to communities about novel vaccines, about clinical studies that had not been exposed or experienced to that kind of research before, and those were life-changing lessons. But I guess what I would say is the way to counteract any of this kind of misinformation is really to start at the grassroots level and to work with communities to communicate to their own communities about vaccines and the benefits of vaccines. And I think perhaps in the context of COVID, we were moving so fast that in some cases we didn't really have the opportunity to set up those allies in communities to be able to explain what was happening to their own communities in a way. We did quite a bit of that, I would say, in the context of vaccine trials. We were doing large studies, trying to get enough representation of different kinds of people in the trials around the world. But I think that's something that we need to look at a bit more. And I think the scientific community needs to really step back and realize that we're not always the best people to communicate the issues to certain communities. And you have to ensure that you have trusted allies in those environments who can help communicate the message. So I think that's where we seem to keep getting it wrong, and those misinformation campaigns will continue.
And Mr. Chair, if I could just add one other point, I don't think this is going to stop at COVID-19 vaccines. The anti-vaccine empire has grown stronger, better funded in this time of COVID-19, but I think it's just the beginning. And I'm worried now about a spillover to other childhood vaccination programs. Measles, for instance, they're targeting HPV vaccine, using some of the same language, claiming that it causes infertility or autoimmunity. And I think we have to be wary of this. And what I'm worried about, I'm worried that all of the amazing gains that we've had over the last 2 decades, in part through many of the people in this room, through the Gavi Alliance and the incredible success stories that have been documented by the Institute for Health Metrics on the success of the Gavi Alliance working with WHO and UNICEF and others. I'm worried that is going to start to unravel now because we've enabled the anti-vaccine groups to become so powerful and have for so long refused to deal with that. I mean, I can't tell you that for years, decades, anytime I would talk about this, I would get rebuked by our own Centers for Disease Control. They would say, Peter, we're not going to talk about this now because you're going to give it oxygen. You're going to announce. So I wrote a piece in the New York Times in 2017 called The Anti-Vaxxers Are Winning, more or less predicting the current state of affairs. And I got rebuked saying, you're just giving this oxygen, Peter. It's got all the oxygen it needs. And I think it's gotten so big and so dangerous that it goes beyond what the health sector can do. I think this even goes beyond the capabilities of the WHO and the U.S. Department of Health and Human Services. We have to bring in Homeland Security, Justice, Commerce Department, and State Department because of the state actors.
Listening to you speak, you remind me of an author who in 1936 published this wonderful book, Sagittarius Rising, in which he describes the calamities of world war. And in one passage, he refers to the invincibility of man's stupidity. And sometimes you have to believe that that's the case. Aurelia, let's turn over to you. Any reflections on the points that were raised or the questions? If you're still with us.
Thank you. Yes.
Yeah.
I mean, a very thoughtful set of comments, which I would also align myself for. Maybe on the topic of humanitarian and conflict settings, I wanted to bring a couple of numbers into the discussion just to maybe help give it a little bit of texture. If you take the numbers as of last month, you had 842 million vaccines that were supplied to countries that are in a humanitarian response plan, or joint response plan, or flash appeal. 85 million were delivered to lower income countries. And we know that there's 70% of the people in humanitarian settings that are within those countries. So just really to highlight, I think the huge need that is there. And before, last year, in many countries, no one was vaccinated. So in a way, the inequity within countries was not very visible. I think now that we're in a situation where supply is coming to countries, we're going to see those pockets of inequities really being left behind. And so that's a lot of the purpose behind putting together the humanitarian buffer, which is really a safety net in terms of having people in humanitarian settings have access to vaccines. But I think it really needs a specific focus now, and making sure that within the interagency setting, we can really give this some effort. So really, from my part, sort of urging civil society organizations, NGOs and others to really come forward and use this this mechanism. And then maybe just the other comments that I would add to the comments on China. So, and thank you very much to China and to other donors for the support given so far to the COVAX AMC. And on developing country capacity, I mean, already I think, you know, progress has been made. When Gavi started, it was procuring vaccines from 5 manufacturers that were pretty much based in Europe and North America. And since 2019, Gavi buys from 17 manufacturers, and 11 of those are in Africa, Asia, and Latin America. We have a very good and long-established relationship with the Institut Pasteur Dakar, for example, in Senegal, which has been really critical to ensuring supply security for the yellow fever vaccine, which was a difficult vaccine market that they help contribute stability to. But I think definitely sort of progress to be made there. And for Gavi, we have a self-procurement policy, and that allows countries to procure locally produced vaccines, provided that the manufacturers meet the international quality standards and the national regulatory authorities overseeing the manufacturers are certified by WHO. So I think there's room for progressing there, and I think it's in everybody's interest in terms of increasing supply security. Thanks.
Thank you, Aurelia, for those comments. I have a request for the floor from the distinguished delegation of the Russian Federation. You have the floor.
Distinguished moderator, I have enjoyed the vast majority of the discussion that has taken place here today. It has been a professional discussion that is very useful in terms of achieving the goals that have been set for today's meeting. I just regrettably cannot leave unanswered the remark of the delegation of Latvia, as well as remarks that are taking place at the plenary meeting. Possibly there will be comments from other delegations as well, but we will only take the floor once to comment. Those statements that are related to the situation in Ukraine. We must note that the basis of our policy is not infringing on the interests of Ukraine and the Ukrainian people, but rather protecting the citizens of Russia and our country itself from those who have taken Ukraine hostage and is attempting to use it against us. And that our provision of military assistance to the republics of Donbass was due to a request on the part of Donbass and related to Ukraine's aggression in their relations. And any attempts to interfere in this situation will be counterproductive. Thank you very much for giving me the floor.
Thank you. I don't see any other requests for the floor. And we have now come to the end of this first roundtable discussion of the high-level thematic debate entitled Galvanizing Momentum for Universal Vaccination. I would like to express on behalf of all of you my appreciation to our extraordinary panelists for their invaluable insights and contributions to the discussion. But before we conclude, I invite delegations to view the pre-recorded video by Gavi, the Vaccine Alliance.
I think it would be not an exaggeration to say that this is a pivotal intervention for the whole world to enable countries with varying degrees of ability to access vaccines to be able to protect their citizens. And this is how it ought to have been, and we're very happy that actually this is how it has actually happened. We're currently able to vaccinate about 1 million people a day on the average.
We've seen a drop in cases of COVID-19, but also we've also seen a drop in the number of severe cases that have been admitted in hospitals. So yes, I could attribute this to the vaccination exercise. I have hope that COVID will surely come to an end if we are able to vaccinate every eligible Ugandan. I want to believe we will be able to fight this COVID-19 disease.
We will continue with the second roundtable discussion this afternoon, starting at 3 p.m. In this chamber. I thank you all for your attendance. The meeting is now adjourned.